Welcome to the podcast tonight. So we're going to talk about pelvic wellness and how it impacts women's sexual health. We've done one of these before. I did this live from the waiting room at the Fairfield office, which was sort of entertaining. So at least now I'm home. All right. So without further ado, we'll get started. So I'm Ann Scott. I'm one of the urologists at the Urology group. I am about 11 years out of residency now. I spent the first 10 years of my career in private practice in Tuscaloosa, Alabama, and then I moved up to Cincinnati to be closer to family. And so it's been almost a year now. So there's a bunch of my badges. Okay, so urology is really billed as especially for men only. You know, we've got testosterone, we've got Viagra, we've got penile implants, but it turns out the field of urology has just as much to offer women as it does for men. I guess we're just not as good at marketing those issues. So that will be really kind of the big focus of what we'll talk about tonight, what we as urologists can offer the female patient, and then kind of focus on how those things that we can offer really improve, particularly sexual health. So sexual dysfunction is really a grossly undertreated issue, way more in women than men. And again, I think that gets to this idea of urologists being for men only, focusing on male sexual dysfunction and not so much a focus on women. So these problems are treatable. We can fix it. And we're going to kind of go through some of the solutions that we have to offer tonight. So as I kind of revised this talk from how I gave it last time, I really kind of tried to focus on female sexual dysfunction as triggered by a problem with our anatomy or a deviation from normal anatomy, a problem with function of our urinary tract causing, sexual implications. And then also a bigger focus on tonight's talk than the last one I did will be about the impact of our hormonal function, our estrogen levels, and then how that impacts sexual wellness. So, why do so many urologic conditions that we urologists treat cause sexual dysfunction? And the issue is simply our anatomy. So this is a really nice cross-section of our pelvis. You can see that the bladder, the vagina, the uterus, the urethra are all just really, really closely approximated. And so if something is out of position or if something is having an inflammatory response, that's going to manifest in a variety of pelvic symptoms, and pelvic pain and issues with sexual function are going to be a part of that, just because that's this part of our anatomy. So the first functional problem that we're going to talk about tonight is urinary incontinence or leakage of urine. And so when I talk to ladies in clinic, I really try to listen to their story and drill down on what the particular kind of incontinence they're experiencing is. For some of us, it's both, right? It doesn't necessarily have to be just one. It could be both. So stress incontinence is not stress like you're anxious, but stress like it's increasing pressure in your belly. So if you do something where you cough or you sneeze, that pressure is going to get transmitted down to your abdomen. That pressure is going to press in the top of the bladder, and that could force urine out of your body. So we classify that kind of event as a stress incontinence event. Urge incontinence, that's leakage that leaks out of us, really preceded by the urge to urinate first. And so you kind of think about that as your bladder, instead of relaxing and actively allowing that urine to come into the bladder at a nice low pressure. That because of the bathroom, and that's kind of how I try to classify it. And the reason for classifying it is that the causes are different and the treatments are different. And so we'll get to some of those here. So again, for coughing, sneezing, leakage, where you can't pinch off that urethra tight enough to withstand that downward pressure, this can happen to us because of genetics, because of bad luck, because of pelvic trauma, vaginal delivery of a large baby, pelvic surgery. And it's a very common problem. So in women over age 45, this is going to hit 1 out of 3 of us. Now, that could be mild, it could be severe, but this is a really, really prevalent condition for us as women, and really not something that we just have to deal with. We don't just have to go buy poise pads. We can intervene. And so this is a little graphic that I tried to create to explain the idea of this pressure mismatch. And I think this really kind of gets to or explains the treatments that we have to fix this problem. So again, this is a bladder, and you can see as that pressure is squeezing on the bladder, that's going to force the urine down. And if that closure force at the pelvic floor, at the sphincter, that's those green arrows, if that's tight enough where it can squeeze tighter than the downward force, we're continent, we don't leak. But if that is not true, that downward force is stronger than the closure force of that urethra, urine starts to leak out. And so these are some different treatments that I talk to women about in my clinic. I think sometimes in medicine too quick to blame everything on weight. Being a healthy body weight is helpful. It's less pressure on our bladder, but incontinence can occur in women that are on the thin side. And so that's not the whole game here, but there are some nice studies that have been done that show that if you're overweight and you do lose 10% of that body weight, that does demonstrate a decrease of leakage. So that does help. Stopping smoking is very important. That really plays to tissue quality. I refer so many of my patients to pelvic floor physical therapy. These are very specially trained physical therapists that have additional training in helping women and men also with strengthening their pelvic floor. And so they can really help people properly engage those muscles, not just kind of clench your butt cheeks, as I say, but really figure out how to engage those muscles and get them strong. And that can really dramatically improve stress leakage. And then the last non-surgical option is something called a pessary. And so that's this picture that's on the side here. Pessary is a medical grade silicone object, looks like that. That would be one that would be on a little bit of a larger side. That's worn in the vagina, and that knob goes in the vagina facing up. And the idea is that knob is going to push on the underside of the urethra and compress it a little bit. And so I wouldn't say that's a common option that we use, but that is a non-surgical option that exists. There is kind of an over-the-counter idea similar to this. That was that Impreza kind of tampon-like device that was marketed. I don't even know if that's on the market anymore, but that was quite uncomfortable. A dry tampon in the vagina is not something that I think is a big seller with us as women. So those are the non-surgical surgical treatments for stress incontinence again. And so now transitioning to what surgeries do I offer women? So classically, if you have stress incontinence, you're reading on the internet, you're going to read most likely about a procedure called a Birch. That was a procedure that was done years ago. By the time I was in training, which was 15 years ago now, none of my attendings did this anymore. It's just something that we read about. There are some places in the country that are doing this Birch procedure robotically. Essentially, it's a surgery where you go in the belly and you're going to put some stitches in to kind of support the bladder neck. The most common surgeries done for incontinence, for stress incontinence, in my hands, I would say probably in the hands of most urologists, are going to be either slings or bulking agents. And for most urologists, me included, overwhelmingly, these were slings for many, many years, even with all this mesh stuff. So a sling is a little piece of mesh of tissue that's going to go around and underneath the urethra, and it's going to act as a hammock to kind of put some support under the urethra so that you can use your pelvic floor and clench things off. We can't put it in so it's tight or you won't urinate. But that's the idea of a sling. Now, a sling can be made of your tissue. And so for some patients, we can make an incision in the abdomen. We can make an incision in the side of the leg, harvest a little piece of their tissue, and then that can be the sling that goes around and underneath the urethra. And so this was the majority of stress incontinence work that I did up until about 2021. In 2021, a new product came on the market called Bulkamid. It's a water-based gel that I actually inject into the urethra. I'll have some pictures of that coming here soon. And so that has really changed my practice, where most of my ladies now, I bulk them because it's a much easier recovery, a less risky procedure, less side effects. And then it minimizes the number of women that go on to need a sling, which then again minimizes the complications related to sling. So that's kind of how my practice has changed and what I'm typically offering. So let's see here. I've got a picture of a sling. So this is, again, that side view of the pelvis. And so that blue thing that you see on the screen, that is the sling. And to do that with a patient asleep in the operating room, okay, totally asleep, no one is feeling this, I look in the vaginal opening and I make a very small incision, about this long, That would be about 2 centimeters. It doesn't project on the screen very well, but a little incision underneath where the urethra is in that anterior vaginal wall. And then I create that little path for that sling to go around and underneath the urethra. And then you see the arms of the sling come up above the pubic bone. So if you could look at this pelvis from the front, you would see that the sling is a U shape. And then that sling is tensioned. The bladder is checked to make sure that the passage is appropriate. The incisions are closed with dissolvable sutures. And that's the surgery. Now, I actually have a little piece of the sling. I meant to do this last time and I didn't have it because I was at the office, but this is not sterile. So we wouldn't put this in a patient, but this is an example of one of the slings that the coloplast super sling. This is what the mesh looks like. I also put in a Boston link sling, and that mesh is blue, but you can see it's very soft, it's pliable, it's stretchy. So that's what a mesh sling looks like. And so again, to kind of talk about mesh. So it's been a little bit now since all of this mesh controversy hit. So I don't think it's quite as much on people's minds as it used to be. I remember when I was talking to patients, 6 or 8 years ago, we spent a lot of time talking about mesh and mesh complications. So largely there was this pullback from using mesh in the pelvis related to mesh kits that were used for prolapse. We'll talk about that later, but that's when the support to the vagina is compromised and our inside organs, instead of being inside, start to come out of our body through the vagina. Those mesh kits had a lot of complications. And so that prompted a lot of attorneys to file these class action lawsuits, and kind of all of surgical mesh got re-reviewed. And so this is a position statement from the governing bodies of reconstructive urology talking about all of the data, the safety of mesh. And you can go to this website here on the screen if you want to read this whole paper. Slings are still a good option, still a common option. And we definitely know how to manage the mesh related complications that can happen, which was a big difference from the prolapse mesh, where women were having just awful complications. And frankly, people didn't really know what to do. So there's a question that I just saw pop up. So can the sling be removed? Yes, it can be removed. I have done that too. Variety of reasons that you might want to do that. As you see here, let me show it again. So, there's a hair on it, so excuse that. You can see there are little pores in this mesh. And so when this is in the body, the body will kind of scar it in place, if you will. The tissue will grow into this mesh. It will encapsulate it and grow through the pores. And so you can remove it. You have to sort of dig it out. It can be technically challenging, but yeah, this is something that can be done. And I've done it, unfortunately, for a variety of these mesh kits many times. Hopefully that answered your question. Okay, so this is a video that is a animation of this Bulkamid product, which is, again, this water-based gel that's injected under the lining of the urethra. New product, just got FDA approved in 2021 on 10 years of data from the European market. Really, I think a game changer for stress incontinence therapy in the US, and really has changed my practice over the last 3 years. So this is just a quick video that will play. Let's see, I think she can play it for me, and it will kind of go through, or maybe it won't play. Let's see. Well, it looks like maybe that won't play. So maybe we can I'll put a link up, or we can send that out so people can watch it. But essentially, sorry for that technical difficulty there. But what it shows is that with a very small telescope, with the patient sedated, I look into the urethra. And so our urethra as women is about 4 centimeters long. It's so short. And so I look in just about this far. And with that little telescope, I have a tiny little needle, and I pass it just under the lining of the urethra. And I make these cushions. And essentially, I'm making 4 cushions so that they kiss in the middle. And the idea is that they're these pliable, soft cushions so that when you urinate, they'll let the urine through. But when you squeeze your pelvic floor, you can squeeze that segment of the urethra tighter. And then from a patient perspective, it's 4 needle sticks. So there's no vaginal incision to heal. There's no mesh to erode. And I have not, to date, since I've been doing this for 3 years now, I have not had anyone persistently not be able to empty their bladder after Bulkamid. So that is a really something that I really like about it that was not necessarily true of previous bulking agents that didn't work so well. Okay, so next functional bladder problem, we're going to talk about urge incontinence. So again, that's the bladder spasticity kind. We also call that overactive bladder. And so overactive bladder is a constellation of symptoms that includes the urge to go hitting you, having to go right now, not being able to delay. And then if you actually leak urine along with those feelings, that's kind of this situation we call overactive bladder. And so when we think about the bladder functionally, it's kind of a feedback loop. And so your kidneys in the middle there, you see, make the urine. The urine goes down those skinny ureters tubes to the bladder. The bladder is supposed to send messages about its filling status to the brain. And then when it's full, the brain sends a message back to the bladder to squeeze. And so this is the kind of functional pathway that goes wrong with overactive bladder, and how you can have a bladder sending I'm full messages. It's not right. And the brain doesn't understand it's being told something that's not true. The brain just goes along with what it's told. And then you can actually have those muscles and the nerves in the bladder actually reflexively squeezing at inappropriate times. So what can cause this? For a lot of people, we can't point to anything. In my patients, I see a super high prevalence of back disease, back trauma, disc surgery, arthritis, back issues, right? Because it's going to interrupt the signaling. Bladder irritants can cause this. Some people so sensitive to caffeine, to artificial sweeteners, to red dyes. Essentially anything that you ingest is going to get into your blood, it's going to get into your pee, and then it's going to bathe your bladder. And so some of us just exquisitely sensitive to that. Constipation, that goes back to that original slide where we showed how all of the stuff for us as women is crammed tightly in our pelvis. If all of that space is taken up by your bowels, there's no room for your poor little bladder in there. And so that can give people that overactive early kind of signaling situation. Anxiety, stress, right? We all know. I had it a little bit before I started this talk where I went to the bathroom more than I needed to just because I got nervous. So that we all kind of know that. And then this is something that actually comes with menopause. The bladder has estrogen receptors in the trigone. And when those estrogen receptors are not getting stimulated because we don't have estrogen anymore, that leads to this increase in overactive bladder that we see in peri and postmenopausal women. So what can we do to stop these things? Lifestyle factors, right? Here we go. So limiting caffeine, painful to admit, but that can help. Evaluating yourself for bladder irritants, treating constipation, drink more water. I have medical medicines that I put people on for this. Mainly these are going to be in a class of medicines called beta agonists. One is called Gemtesa, one is called Myrbetriq, both very effective for treating overactive bladder with a much better side effect profile than the old medicines. Vaginal estrogen therapy, again, fix those estrogen receptors in the trigone, can be effective for reducing overactive bladder. And then I have some procedural interventions. I inject Botox in the bladder. I do what a lot of people refer to as a bladder pacemaker. That's sacral neuromodulation. There are two companies that do that, Medtronic's InterStim and the Axonics implant. And then this new space, there are these companies that put stimulators in the ankle. And so that's kind of a new area that's actively evolving right now. So Botox in the bladder, most of us, probably a lot of us know what Botox is for wrinkles. I could use some more. Botox is a neurotoxin. So it works in your forehead by paralyzing a little bit of your forehead muscle. You can't move your forehead. That's why your wrinkles go away. And so same idea in the bladder. I look in the bladder with the telescope. I inject 100 units of Botox in a grid pattern on the back wall of the bladder, 10 spots. And that's going to deaden some of that bladder muscle. And what that means for most women is it calms down their overactive bladder symptoms. I would say on average that lasts 4.5 months. Big risk here is not emptying the bladder. Risk is 1 or 2%, but every now and then it happens. And that's really, that can be a negative experience for a woman if she has to catheterize. Thankfully, not that often, but it can happen. So this is the idea of the bladder pacemaker. So this is an implant that I put next to the S3 nerve root in the sacrum. And so this is an idea that I think is really difficult for people to get their heads around. But again, it goes back to that earlier slide that I showed about the signaling pathways. So in our back, we've got all of our vertebral bodies stacked, and then we've got an upside down bone, which upside down triangular shaped bone called the sacrum. Solid piece of bone. It has openings in it. And so in the operating room, I can see those openings. I can count down to the third opening. That's where this S3 nerve root runs. That's the nerve root that does bowel and bladder function. And if a patient is awake, I inject some numbing medicine. If they're asleep, I pass a little needle. And I essentially am going to pass that needle through that opening in the sacrum bone right next to that nerve. And I'm going to stimulate it. And that's how I know that it's right. If it's right, I pass a little piece of wire through that needle. I remove the needle and I hook it up to a temporary battery that's taped to the back. And for a week, the patient will get to wear that and see, what does this do for my symptoms? Is it a home run? Does it not do anything? Does it fix half of my symptoms? It's like test driving a car. And I think it's a really helpful idea because very difficult to get your mind around what this therapy is without really seeing and experiencing it. So that's the trial. At the end of the trial, that temporary piece of wire in the back with the dressing, that all comes off. You don't have anything in your body anymore. I would say 7 to 8 out of 10 patients find it to be extremely helpful for their symptoms. And then they would go on to having a permanent implant put in. So same steps, but asleep. If they were awake the first time. And then what you see on the screen in that gentleman's hands, those are the two different batteries. One is a rechargeable battery that lasts at least 10 years. The smaller one is the big one is a non-rechargeable battery, lasts about 10 years. The smaller one is rechargeable, and those can last out to 10 or 20 years, especially with the Axonics battery. They last quite a long time. There's a little QR code in the corner. That is for the Medtronic implant. They have a patient app called My Journey that has more information on overactive bladder and actually would put you in touch with Melissa, our Medtronic rep, if you would like to talk to her about this therapy further. But this is a really nice option. And it, once you go through the steps, a patient that chooses this, at least the nice thing versus Botox is they're not coming back and getting treatments, 2, 3, 4 times a year. So you've had something and it's done. Okay. And then, so this is an office-based treatment. It works. The biggest issue with this is that you have to sit in our office. And so, we cover so much of Cincinnati. This is only available at our Norwood office. So I do think that is a little bit limiting for patients, but this is a therapy where you would come in and we would put this little device you see pictured in your ankle. And so you have a nerve that runs in your ankle right under the skin, and we can stimulate that nerve. And the idea is that message, that stimulation is going to go up your leg, and it's ultimately going to impact the feedback loop between brain and bladder, again, using similar pathways to the InterStim and Axonics devices we just talked about. But again, this is an office-based therapy, which is limiting. There are these new implantable stimulators that are coming out to kind of address that need of how patients don't want to sit in our office, which we understand. I've been trained on eCoin, and so that's the Valencia one you see. And so this is kind of a mock-up of what that is. This little device goes underneath the skin of the medial ankle. And so there, again, that's where that nerve runs. And so this would sit right on top of the nerve. It's going to stimulate the nerve and, again, fix those signaling pathways. This other device is by, what did I do with it? This other device is called the Revi device. And so you can kind of see it's this tiny little thing. And so this is implanted, again, under the skin of the ankle. And then you stimulate the nerve using this by wearing this ankle bracelet that you see on that gentleman's ankle. That would be worn for 20 or 30 minutes in the morning to do the treatment, to achieve the same thing as that office-based therapy I showed. These are coming soon. There have been some difficulties getting these off the ground, largely because of insurance issues, but hopefully with some coding changes that we're anticipating, that will be a more viable option in the near future for patients. Okay, so big transition here. So now we're going to talk about the role of a vaginal bulge in pelvic wellness and its impact on us women functionally. So, our pelvic floor, what keeps our pelvic organs in our body is this combination of muscles, of ligaments, of connective tissue. And so if that support is compromised, things start to sag out of our body. And so you see in the lower picture where that blue arrow is, that's the bladder actually kind of pushing into that vaginal canal and coming out of the body. That medically is called a cystocele. And so these are, I think, somewhat confusing words that we use to describe when we have a bulge coming out of our vagina. What is that bulge? And so the one all the way on the left of the screen, that would be a little bit of the bladder. That's called a cystocele. The one adjacent to it, that would be the back wall of the vagina moving forward, and that would be the rectum pushing into that space. The third image, that's the uterus actually trying to just come out of our body, which is amazing that this happens to us, but indeed it does. And then the last one is a woman that's had a hysterectomy, and that the vagina then is just sort of like a sock, almost kind of like a blind ending pouch. And what can happen with vault prolapse is it's almost like the sock is pulled inside out. And so that can happen. And that's vault prolapse there. And so prolapse, kind of like stress incontinence, extremely common for us. 1 in 4 women by age 40, 1 in 3 by 60, and then 1 in 2 by 80. So again, an extremely common problem. What are the symptoms? How would you know? Well, most women, if they come to see me for prolapse, it's the first thing they say. They say, there is something coming out of my vagina. There is a grapefruit coming out. There's an orange. I feel something when I wipe. So that, I would say, is the most common thing. The other symptoms that women describe: heaviness, pressure. It can cause some painful intercourse. It can affect a woman's ability to empty her bladder. It can make her bladder unstable. She can be leaking. That can increase the risk of urinary tract infection. Some women find that they can't empty their bladder at all or have a bowel movement, and they have to use their hand to reduce the bulge. So these are all things that I hear in history. And then why does this happen to us? Again, a vaginal childbirth can disrupt all of that support in our pelvis. Pregnancy, as we get aging, the effect of estrogen and lack of estrogen on our bodies as women, obesity, pelvic surgery, constipation. A lifetime of lifting heavy things, I think, can kind of beat on that connective tissue and that support. And then if you actually had a connective tissue disorder, that would increase your risk as well. So what are the treatment options? So for some women, they don't have a whole lot in terms of bother. And so there are plenty of women with lower grade prolapse. It's not that severe. They don't have any symptoms. We don't have to do anything about it. If they're not bothered, it's not necessarily something that we have to fix. I also do really believe in the role of pelvic floor physical therapy again for this, engaging our core properly, lifting properly, making sure that we're not just loading through our pelvis, but loading properly. That can certainly reduce the risk of progression, and then tightening those muscles can help. So I think there's a big role there. There is a device that I fit women with called a pessary. We talked about this earlier in the context of coughing, sneezing leakage. But again, a pessary is the space-filling silicone object. They come in different sizes, and it's worn in the vaginal canal to kind of act as a shelf and hold whatever the prolapse is up, right? And then there is a surgery. There are surgical options for repair as well. So for me, the most common surgeries that I offer women for prolapse, I offer something called an A&P repair, or a cystocele rectocele repair. That is a surgery done through the vagina, where the layers of the vaginal wall are sewn with stitches to try to recreate that support on the top and bottom layer. I do not use mesh in that space. I don't really think anyone does through the vagina anymore. That repair is really limited by a lack of durability, unfortunately. The repair I probably do most commonly is a robotic sacrocolpopexy, which is a mouthful. That's the surgery that's depicted in that image to the left. And so that is a surgery done through the belly using a robot. Little incisions are made in the abdomen. The vagina is dissected out from the inside, and then I use a Y-shaped piece of mesh. You see on the picture how it's Y-shaped. The arms of the mesh go around the top of the vagina, kind of like this. And then the tail of the mesh is sewn to a ligament that lives in front of the sacrum. And the idea is that you're going to resuspend that vagina with this kind of continuous layer of support so that everything stays in the body like it ought to. And then the other surgery that I do is something called a colpoclysis. That's a surgery for a woman who is done engaging in sexual intercourse and is certain that she will feel that way in the future. And so for a woman who feels that way, this is a surgery done through the vagina, much easier to recover from, where the canal is just literally obliterated. The top wall is sewn to the bottom wall. So how do you prevent prolapse? Sometimes you hear these stories and you think, oh Lord, how do I, keep this from happening to myself? I mean, some of these things, it's just luck, right? But, maintaining a healthy weight, not smoking, lifting properly, staying in alignment, Kegel exercises, all probably can help somewhat. Okay, transition. So functional bladder problem now, recurrent bladder infections. This is a big common issue for us as women and really does play with sexual dysfunction, because many women come see me and they say, I don't want to be intimate with my partner anymore. I get an infection every time, or I'm having pain. So this is a common thing for us. So why do we see infections? Well, the cause of infections actually changes for us as we progress through our life. So in infants and small children, largely infections are going to be driven by anatomic issues with how the ureter and the bladder are connected, issues with not properly figuring out how to empty our bladder, doing it regularly, struggles with constipation. As we kind of figure out how to void properly, how to organize, control of our bowel and bladder, we kind of see that those infections go away. And then in adulthood, there's another big spike that really does correspond with initiation of sexual activity. And for us as women, very difficult, our short urethra, we're going to get bacteria in our bladder. Some of us just are able to go to the bathroom after, empty out well enough that we don't get infected. I think for some other people, their threshold is just quite low, and it really kind of almost doesn't matter what they do. They're just very easy to infect. And then later on in our life after menopause, that estrogen status change is just critical. And we see a huge increase in urinary tract infection related to lack of estrogen in our bodies. We'll talk about that more. And then also, I think mobility changes, increasing incidence of diabetes, increasing incidence of incontinence. You've got a wet pad against the urethra. None of these things help that kind of microenvironment, that ability to kind of repel the bad bacteria. So those things all really start to play a role later in our lives. So what treatments do we have to offer? So for the premenopausal woman, difficult space. Most women, by the time they've gotten to me, have tried everything they can try. They're not holding their urine. They're drinking lots of water. They're managing their bowels. We offered women cranberry supplements. We offered D-mannose supplements. And then there's this paper that just came out a couple months ago, published in JAMA, a very nice, well done, randomized clinical trial. No benefit for D-mannose for prevention of UTI. So that was a sort of devastating paper. You can't help but wonder if they did a nice paper on cranberry, if it would be the same kind of lack of efficacy as well. So in this premenopausal space, we really don't have a whole lot to offer women. If a woman tells me that there's a very tight association of sexual activity, this is when I will offer antibiotics to take with intercourse, with the idea if we can have some antibiotic meet the bacteria in the bladder right after intercourse, that single dose could prevent infection. But not my favorite. I think avoiding antibiotics as much as possible is important, but the reality is that we don't have a whole lot of other things to offer in that space. For my postmenopausal women, this is where the role of vaginal estrogen comes in big, making sure also that people are not holding their urine, emptying completely. And then again, we can be left with suppressive antibiotics. That's an antibiotic to be taken every day. Not my favorite approach. And then for all women, both pre, peri, and postmenopausal women, there is a UTI vaccine out of Spain that's in trials where the data looks very promising. So I have my fingers and toes crossed that will be something that we'll be able to offer women, hopefully at some point in the relatively near future. So the role of estrogen in UTI is a nice segue into kind of an overall hormonal problem that has huge sexual implications for us as women. And so that is something called the genitourinary syndrome of menopause. So we abbreviate that GSM, and it's sort of poorly named because this syndrome for us actually starts in perimenopause. And so I'm going to spend some time kind of explaining that. And so what is GSM? So genitourinary syndrome of menopause is a constellation of symptoms that happen to us in the pelvis from lack of estrogen. So dryness, painful intercourse, irritation, itching, these overactive bladder symptoms we talked about earlier, including incontinence, and then infections. Some women have all, some have none. And so this is something related to menopause. And so I thought it would be nice to take a minute here and just explain actually what that means in case people didn't know. And so for us as women, when we're born, we have every egg that we'll ever have. And then over our lifetime, those eggs are lost. Some are ovulated, but most just become atretic and die until we hit menopause. And that for us is going to hit between 40, 58, somewhere in there. And menopause is when you don't have any functional follicles left. And so why does that matter for estrogen? The number of eggs, how does this estrogen thing come into play with the eggs? And so these are my fancy new slides I made. So there is a feedback loop in our bodies between our brain and our ovaries. And the ovaries, that is where most of our estrogen is made, obviously before menopause. So the brain sends a signal to the ovary, and that's this egg thing I did. And that signal is FSH. That makes the ovary make estrogen. And that starts to recruit and prepare a follicle to ovulate an egg. And so that estrogen keeps rising until ultimately there's a feedback loop to the brain. The brain releases a hormone called LH, and we ovulate. And that's also when progesterone is made. And so this is the normal cycle that's happening in our bodies over a month. We keep having these surges of estrogen, these surges of progesterone, until menopause, there is no more follicle to recruit. And so at that point, our estrogen levels fall. And so in this top graph, you can kind of see the distribution of kind of what's happening in our bodies over time. So all those colored lines at the top, those represent the two signals from the brain, FSH and LH, and then the oestradiol, it's a British spelling, but you can see how the estrogen level is going up and down. Now in the bottom graph, in the middle, that's menopause. And so before menopause, we've got our estrogen level going up and down, but the overall trend is pretty high. When there's no more follicles, there's no more estrogen to be made, and then it's just quite low. And so that has huge relevance for us because those estrogen receptors are all over our pelvis. They're in our vaginal tissue, in our vulvar tissue, in the urethra and the bladder. And so particularly we see that lack of estrogen decreases vaginal blood flow. It decreases the elasticity, the softness of the vaginal tissue, decreases glycogen, changes the pH. All of that matters for the vaginal microenvironment. The urethra moves closer to the vaginal opening, making it in the prime condition for us to get urinary tract infections. Our bladder gets spastic, and there are even receptors in the muscles of the pelvic floor. So maybe that is more implicated in prolapse than we think. So lack of estrogen does all of these things. And that's really how all of this, how all of those changes in peri and postmenopause really just lead to urinary tract infection for us because of these changes. And so fixing this, offering a woman a vaginal estrogen is going to, reduce urinary tract infection in this space by about 60%, depending on what paper you read. And in my practice, I have women that are having recurrent infections. We start them on estrogen, they come back, maybe they have one a year or one every 2 years. So it's dramatic, the quality of life improvement that just a simple intervention like restoring a little estrogen in the pelvis can make for women. So here's a question about this. So is it ever safe for a woman that had breast cancer to use estrogen? So yes. So, estrogen got a bad rap when that women's health study came out all those years ago. There was an arm in that study, and that was a study of hormone replacement. Okay. That was where they gave women oral estrogen to raise the estrogen level in their body. And in the arm of women that took estrogen and progesterone, there was an increased incidence of breast cancer. So later studies actually show that was probably from the progesterone they used. In the estrogen only arm, there was actually fewer breast cancers. But what we're actually talking about here is not even systemic estrogen at all. So we're talking about just local vaginal estrogen. So this estrogen is not detected in the blood. This is safe to give to breast cancer survivors. The only space where I have paused prescribing a vaginal estrogen to a woman is a woman that was just diagnosed with breast cancer and is on an aromatase inhibitor. That's a medicine that's designed to drop down the estrogen in a woman's body extremely, extremely low. We don't have a whole lot of evidence in that space. There are like 2 papers. And so, that's a difficult space. So I do have some women where I've prescribed it. That is a informed decision between that woman. Often she'll talk to her oncologist about it. But if she's so severely bothered, on balance, she might make the decision that just using a very little bit to try to prevent these infections is on balance worth it for her. So, but a woman who's been treated, who's done with the aromatase inhibitor, lots of data, totally safe. Do it all the time. Does vaginal estrogen decrease stress incontinence? Some evidence says yes. Now, I'm careful. I think if the incontinence is quite mild and the vaginal changes are severe, I think maybe that could have a significant role. But if the incontinence is significant, I think it's probably a multifactorial thing going on there. And that's a woman where I would probably offer her a vaginal estrogen, because I think pretty much everyone should have that. And would also offer her some sort of intervention for her stress incontinence, be it pelvic floor physical therapy or maybe Bulkamid. And so this is kind of me, right? I'm Oprah in this meme. You come to my clinic, you're going to get a vaginal estrogen. And so these are the typical vaginal estrogen products that I use. So the top one is a cream. It comes with an applicator, which most of my patients do not use. They rub it on their finger. They rub it around inside the vagina. Any of that skin from that labia minora, as deep in our body as it goes, that is all fair game for this cream. The middle thing, that's a vaginal estrogen insert. And so let's see, do I have a pen? It comes in, like this is a clicky pen. That's kind of like a clicky pen applicator is how I describe it. Each of those is single use. There's a little tablet loaded in the tip. It goes in the vagina. You eject the tablet. It melts into the skin. That's done twice a week. And then this last one might be my favorite, but this can be an insurance. This can be difficult to get with insurance. So this is actually DHEA that's done daily in the vagina. And what's nice there is that DHEA is a precursor of both estrogen and testosterone. And so that does put a little testosterone in the vagina, which it turns out there are androgen receptors there too. So a little androgen in the vagina is nice as well. And so there are always cost issues. So a little plug for Mark Cuban's Cost Plus Drugs Pharmacy for anyone that is getting any sort of generic medicine. So he's currently got the cheapest price for vaginal estrogen cream nationally. His tube price there you see is $13.22, $5 shipping. Difficult to beat that. So what about systemic hormone replacement? So that's a huge lot to talk about there. Huge impact in sexual function, right? If you're not sleeping, you're having hot flashes, your energy is poor, you're having joint pain, all of these are menopausal symptoms, you're probably not going to have great libido, right? So this is an important thing too. So I'm actually about halfway through doing some classes to get my own personal menopause certification so I can appropriately do it safely for people. And then these are some other resources I included that are really great. MIDI Health also is a online telehealth company that takes insurance and does evidence-based menopause care for women. So some nice options there. Nice transition here. So hypoactive sexual desire disorder. So this is a disorder where we have, we don't have interest in sex. We have no libido and it's bothersome. And so this can happen to us as women throughout our life, before menopause, perimenopause, after menopause, a multifactorial disorder for sure, right? Some of it's thought to be due to an imbalance in the brain with neurotransmitters. There's some medicines that can cause this. And then, you can't understate the role of things going on in the relationship and then also psychological things going on. And so we actually do have treatments for this, which this is poorly known too. And so I'm going to drink a little water, excuse me. So there is actually a lot of data for topical testosterone for us as women. This is largely done in the peri and postmenopausal space. For us as women, we dose it at 1/10 of the male dose. So that is a little tube of testosterone gel called Testim. A man would get a box of 30 of those and he would apply 1 per day to the skin. So for us, we would take one of those little tubes and instead of applying the whole thing, we would apply a pea-size amount. And so that little vial, which is, I mean, gosh, about this big, it's tiny, lasts us about 10 days. And so that's a really nice option. You want to kind of follow a woman for 8 weeks, 12 weeks, kind of look for response. We can follow levels, and sometimes we do have to dose adjust people a little bit, but don't see a lot of side effects there. At our office at all of our offices, we actually just got this week, which is very exciting, a oral testosterone for men called Kysotrex. And so that is something that I do think we can use for women. We'll have to dose adjust it, but a pill option is always nice. So let's see, next slide. So this is a FDA approved medicine for women who are premenopausal. It is a pill. It was called Addyi. The generic name is flibanserin. And so it is going to work in the brain by balancing neurotransmitters. Women that take this, note about a 50% increase in satisfying sexual experiences or events. And I would say about half of women that take it are responders. It's a pill that you take every night. When this first came out, it had a bunch of labeling on it that said that if you took this medicine, you couldn't ever drink alcohol because this medicine is a little bit sedating. And so that they've done subsequent studies and kind of walked that commentary back. So you can drink some alcohol with this, but if you're going to have, 3 or 4 drinks, you would want to skip your dose that night because, you wouldn't want the additive effects of sedation. But a really nice option for us, and a side effect of improving sleep quality, which is an issue for a lot of us starting in perimenopause and postmenopause. So a pill that improves our sleep quality and then also improves desire and libido is a nice option. The last option in the space, and I should say this, Addyi, let me go back. Addyi is FDA approved for the premenopausal woman. It is not FDA approved for postmenopausal women, but that said, there is data that it works. So in that space, there are some women that elect to use it off-label, and the PhilRx specialty pharmacy does have fairly competitive cash pricing for those people. Last option in this space is something called bremelanotide. Bremelanotide is an injection. So that's an auto injector you see. So when you would want to be sexually active, you would dose yourself with this medicine, and then it would hit and hopefully improve your libido and desire. I don't use a whole lot of this. I think it's a good medicine. The big side effect is nausea. And so when I go through this with patients, women are much more interested in having improved sleep. They're much less interested in having nausea, which is obviously not going to improve your mood. Okay. So a functional problem, pelvic pain. We've already kind of focused a little bit on when we can have vaginal pain or pelvic pain as women. Some of that can be a hormonally related thing, related to kind of dryness and lack of estrogen, like we talked about. But there are a whole host of other things that can cause us to have vaginal pain. And so, we have, again, all of those muscles in our pelvis because of trauma, because of surgery, for a variety of different stories that I hear. Some of us can start to have this kind of hyperactivity in the muscles of our pelvic floor, and that can cause pain. And so that, that's a diagnosis where we really work with our pelvic floor PT people. And then we use medicines in the vagina, kind of break that cycle of vaginal pain. There are other skin conditions, not just the skin changes from lack of estrogen, but other skin conditions in the vagina that can cause pain. There's a bladder pain syndrome called interstitial cystitis, where vaginal pain is part of it. There's a syndrome called vulvar vestibulitis, which can be an imbalance in estrogen and testosterone in the vulva. Sometimes that can be related to actually taking birth control pills. That can be very painful. Adhesions covering the clitoris, painful, difficulty orgasming, lots of things in this space. So the treatments, as everyone would guess, really vary based on what the findings are, what the story is, but a lot of things that we have to help people to kind of really drill down into what is the cause of their pain and kind of break that pain cycle in a variety of ways. Okay, so, I missed a couple questions, so let me do these. So the question is, I'm 47 and I had a total hysterectomy, ovaries tube, cervix, fallopian tube, so everything. And I've used vaginal estrogen for about 4 months and I've seen some improvement. I still have painful intercourse. Would systemic estrogen potentially be helpful for me? So I think yes. And I don't know why you had your total hysterectomy, but the data, and again, I'm still halfway through my class, but there seems to be a lot of data just about the importance of estrogen in our bodies as women, kind of up to normal time of menopause. And so 47 is a little bit on the earlier side. Estrogen is so important for bone health, among other things. And so this is where really the nuance of hormone replacement comes in. What's the benefit risk ratio? But do I think a systemic estrogen would be potentially helpful for you? I think yes. My other question is, I wonder if we've really dialed you in enough on the vaginal estrogen. I don't know if you're using a cream or a tablet. If you're using a tablet, I might also give you a cream, right? I would want to do a pelvic exam and see what that tissue looks like. Maybe we're not using quite enough cream. There's a lot of anxiety, again, around using estrogen. And am I going to use too much? Am I going to cause myself to have cancer? Really, a lot of that is overblown, but that's where kind of this nuance comes in. And so I think definitely tweaks could be made to help that pain. And then my other thought too is, is there kind of a pain cycle in there, right? Was there pain because of dryness? Maybe now the skin is better, but there's hyperactivity, kind of this, because the pain was there before. Do we need to do some work there on relaxing the pelvic floor? So a lot of questions, a lot of thoughts. With the testosterone gel, what would the testosterone gel do to me since I have PCOS with lots of facial hair, male pattern baldness, and other side effects of high testosterone? So, that's where when I start people on testosterone, I check a lab at baseline. And so I would want to know what your lab was, your baseline, because if you are already riding high, which with those side effects, I would suspect that you are. I don't know that testosterone would necessarily help you achieve your goal. I might pick a different option for you. What happens when you've been using vaginal cream for years and now I'm having pain with intercourse? Well, I hate that. I would want to do a good pelvic exam. Something else might be going on. And so definitely I'd have you come see me or go see your OB. But yeah, we definitely should be able to help you with that. Does a vaginal cuff after a hysterectomy prevent prolapse? Oh, I wish. No. So when a hysterectomy is done, you've got the vaginal vault and then you've got the uterus. And the point that connects the vault and the uterus is called the cervix. And so a woman that has a complete hysterectomy, we use all these different words that it makes it confusing. But if the entire uterus and cervix comes out in the operating room, what your gynecologist is left with is the vaginal vault that's got a big hole at the top. And so they sew it shut and they call that closure the cuff. A lot of the OBGYNs will maybe tack the cuff to the ligament to try to prevent the cuff from prolapsing, but sometimes it still prolapses. So no, a cuff just means that there's no more cervix. And no, the fact that uterus is gone, that really can increase the risk of prolapse. Let's see. I think I did. Oh, yes. Last question. Have I seen patients with EDS? Yes, I have. So EDS, for those that don't know, is Ehlers-Danlos syndrome. And so that's a connective tissue disorder. And I think we popped that in a bunch of slides as a risk factor for some things. So yep, I have. I think that is the last question. So the pop-up, this was the Bulkamid video that I kind of boogered up earlier. So if y'all want to watch that animation, you should be able to click it and watch it. And maybe when we send this out, we'll be able to include that for people as well. But I do think if you Google it, last time I checked, I do think they have really nice patient-facing materials. And also you can come see me. So thanks everybody for your time. I'm currently seeing patients at 3 different locations in the urology group. I'm at our Fairfield office. I'm in Middletown, which is at the Atrium Hospital up there. And then I have a clinic in Norwood as well. So I appreciate you all taking time to listen to me blather on. I hope it made sense. I hope it was informative, and have a good evening. So, all right.